Okay, everyone. Hi, I'm here with a very talented and very special person here, Dr. Mimi Garneri. She is very well respected in healthcare in general, but definitely in the functional medicine community. And she's the past recipient of the Linus Pauling Award. And she has a very interesting history going from cardiac stent surgery into integrative medicine, into functional medicine. And she's also organized the Academy of Integrative Health and Medicine, and has a conference every single year, which is fantastic. So thank you for joining us.
Oh, it's great to be here. Thank you for having me.
All right. So can you tell us your story? Because your story is very interesting. That you're at UCSD, right, as a stent surgeon?
Yeah, no, actually, I was at Scripps. I trained in New York at Cornell, New York Hospital, and then NYU for cardiology. And you have to remember, it was the 1990s, 1993, when the first stents started to come out. And Scripps was a pioneer of the Palmar-Schatz stent. So in 1994, I came out to Scripps in La Jolla to work with Richard Schatz. And it was an exciting time because the stent was a new procedure. Coronary stenting was a game changer. I mean, most people don't realize we used to send people to bypass surgery for what we can do in 15 minutes with a stent today, right? So it was a really exciting time. And I began to do a lot of interventional cardiology, up to 700 procedures a year sometimes.
Wow.
And yeah, and it was kind of fun. One day I was coming out of the cath lab, and I remember I just stented someone's right coronary, and right behind the door, right there, was Dean Ornish. And for those who don't know Dean, Dean was really a pioneer in lifestyle medicine. He was studying many of the approaches he learned in India. Can we use yoga and meditation, vegetarian diet, exercise, group support, and sense of community to transform cardiovascular disease? And when he approached me, I have to say, I thought, this is crazy, because my whole world was the world of a interventional cardiologist, right? I had no real paradigm of functional medicine, holistic medicine, lifestyle medicine. And so I reluctantly agreed to do research with him. And the reason I agreed to do it was there were clearly people we couldn't stent or bypass. They were people that were honestly being told, hey, go home and, take it easy, or get your affairs in order. I mean, all these crazy things when you can't do something for someone. And so we decided we would study lifestyle approaches in these very, very sick heart patients. And that led me on a journey of transformation.
Right. What did you see in this study that really was shocking to you? Did you see some rules of heart disease? What did you see?
It was kind of interesting to me, again, as an interventional cardiologist, because I would go to the program with the patients, right? So I hired the best nurse I can find, who was an ICU nurse, Ronnie King. I literally dragged her out of the ICU because she was a long-term TM meditator. She really understood the world that I didn't understand. And so we would take these patients, and 3 days a week, they would do 4 hours cooking school, yoga and meditation, walk, group support. And it became this incredible lifestyle intensive. And what I realized was, my God, we were really changing lives. I mean, yes, people were losing weight, their attitudes were changing, they were opening their heart without open heart surgery. They were talking about things that really mattered. And their A1Cs were going down, their cholesterol was going down, their weight was falling off. And I had to stop and say, okay, there's something here. And it's not just to say that what I was doing with my stents was a bad thing. There's a time and place for everything. In the middle of a heart attack, opening the coronary artery is the way to go, right? But I thought, we're so good at intervention and we're so bad at prevention and lifestyle. How can we bring these two together?
Yeah.
And that's what led us to create the Scripps Center for Integrative Medicine, because after we finished the Ornish research and we showed you can actually reverse plaque in vessels, and we showed that people can actually follow a lifestyle program and lower A1Cs, lower cholesterol, we said, so we can't just stop the work. We said, studies over, no more lifestyle change program. We said, no way, let's create the Scripps Center for Integrative Medicine. And that's how the center came about. Ronnie King and I created it as an offshoot, if you might, of the research we did with Dr. Dean Ornish.
What year was it?
1996, 97, 98, right in there. And it was an interesting journey because at first we were sort of clandestine, if you might. I was still putting in a lot of stents, so making a lot of money for the hospital. Yeah. So people, administration didn't quite care that I would run across the parking lot to some offices that we called, our squatters space. We just took over some office space and, teaching people yoga and meditation. That was like, we were off the radar screen, right?
Yeah.
And then what started to happen, which was fascinating, is people were getting better and better, and they became donors for our program. And they said, look, we want everybody to have this. We want to give money to this. And we went from this sort of hiding in the basement of Scripps, if you might, bohemian program, to creating the Scripps Center for Integrative Medicine, all with donor money and so on.
Yeah.
And the reality, and people need to know this, look, hospitals are good at what they do. They're good at acute care. And I spent about 20 years trying to convince acute care health setting that we needed to focus on prevention and lifestyle. But quite frankly, that's not where they make their money, and that's not where their expertise is, right? So we did a lot of work with donor money and bringing in things like acupuncture and healing touch and mindfulness-based stress reduction and vegetarian cooking school, and you name it, we did it. And it was really, it was wonderful. It was just this wonderful world. And every other week we would hear knock on the door. Well, you have all this space. Well, we can make more money if we put dermatology into your space. We can make more money if we convert your yoga room into 6, exam rooms. You can just imagine this, right? And eventually that's where the pushback began, because we were so successful and the donors were so happy to have us and give money to us that, I said, look, we have integrative cardiology, which of course was what I was pioneering at Scripps. I said, and let's have integrative gastroenterology. Let's do a functional approach for the gut. Let's get a neurologist in here, women's health. And that's when the hospital system said, no way. Right. And even though we had millions of dollars to do it, they felt like we were trying to run a parallel healthcare system to what they were doing. And I think what they feared, quite frankly, was people loved us and people gave us money, right? and so it became a little bit of a tug of war where they try to restrict what we can do. But I have to say that the journey has been a fascinating one and one of a lot of learning.
Yeah. So, when I first heard you speak and first heard your story, I was like, okay, it takes a very special person to go from the world of surgery into all of a sudden and then shift into integrative medicine because they saw something change. Like, that doesn't happen. That doesn't happen. People will just go, I'll refer out to it. But you took the charge of like really making integrative cardiology the best you can make it at the limitations of the policy issues and money involved at academic center. Now, for people that are practicing functional medicine in our community, we have a lot of functional medicine practitioners, and there's some areas of confusion about cardiovascular prevention and disease and imaging and testing and lab markers and diets and all those things. So I was hoping I can, tap into some of your experience and your specialty in cardiology about that. So let's start with diet. So when you first did this study, you guys were doing a vegetarian diet and you saw plaque reversal. But now we have so many different diets. We have Mediterranean diet, we have ketogenic diet, we have, carnivore diets, all these different diets. So what's the main deal? Is the main deal with diet just to lower insulin? Is it really the saturated fats? What do you think?
Yeah, I really think that if you're right, we have this debate about diet. Now you can take it from a full research perspective and you can say, okay, there's level A evidence, which there's very little level A evidence in anything.
That's very true.
There's level A evidence in cardiovascular disease for a true Mediterranean diet. I observed this, which was a learning point for me. There were people within the 10% fat vegetarian diet who did incredibly well. We had a lot of men in the program. I used to call them my lean, mean fighting machines. They lost all this weight. Their energy was abundant. Their angina went away. We had a 91% reduction in chest pain. And they really stuck to a proper carbohydrate vegetarian diet.
Right.
Then we had this other element of people who said, okay, well, I could do a vegetarian diet, but that means I could eat fat-free cookies, I could eat fat-free cake, I could eat, and they started carbing up. And those are the people where we started to see the atherogenic lipoprotein profile show its face, right? The low HDLs, the high triglycerides, the particle numbers go up and so on. So the first thing is, what are people really eating? And I think what we can all agree on is sugar. I'm totally push my patients no more than 20 grams of added sugar a day. And I really push my patients to be on a strict low glycemic diet. And the more I can do personally with vegetables, low glycemic vegetables, is sort of my direction to go. I think we have enough research to support a Mediterranean low glycemic diet. And I think we could live with that. Now, when we talk about keto diets, yeah, I have people I see in here with seizure disorders. I might want to really get them off all the sugar, particularly gluten and simple carbs, and shift them to a more keto or keto flex diet, get the good fats in, right? And I'm not against the good fats. I'm not against, the olive oil, the nuts and seeds, the avocado. I think even for cardiac patients, that's good. I mean, Predimed, although it was a primary prevention study, used good fats and showed a 30% reduction in events. So I like to tailor it to the individual, but I do not believe that we have data to support, beef, pork, lamb, full fat dairy, as a way of life, gravy as a beverage. I don't think we have the research to support that as much, but I do understand that people use the animal products to try to get themselves off the carb loading, right? So,
you think it's a combination? You think it is like with the diets, the junk food vegetarian diet obviously was terrible because we're still eating a lot of carbohydrates and insulin surges. So do you think the dietary issues mostly mechanisms of getting insulin down, increasing their fiber, changing their microbiome?
Totally. I think that's the key. I think, I agree. The way we teach it in functional medicine, which started when Mark and I really started the cardiovascular module. It's really about inflammation, oxidative stress, and immune response. And if we can keep the inflammation down, insulin is a driver of that. Stress is a driver of that. Food sensitivities, heavy metals, sleep apnea. I mean, all of these things are drivers of inflammation, which ultimately are going to lead to endothelial dysfunction, right? And reduction in nitric oxide. So
Sure.
I think that's a key piece. And how many vegetarians do I see who say, "Well, I eat macaroni and cheese"? Well, that's not the vegetarian diet that we're talking about.
So with vegetarian diets, what do you think of gluten and dairy in there? What, do you check for sensitivity? Did that change things if it's inflammatory? What's your thoughts?
Yeah, so I need to, again, I'd like to personalize it. If anyone, I always believe in starting with the gut. And the patients say to me, "Why are you starting with the gut?" Right? Because the gut is a potent source of inflammation. And that inflammation, as you know, can lead to everything from cognitive decline, cardiovascular disease, to depression, and so on. And frequently the inflammation is in the gut. So I do a really good intake around bowel habits. I mean, I really want to know how many bowel movements people are having, what it looks like, is there food in there, do they have gas and bloating, when do they have their gas and bloating, do they have heartburn? What you find is a host of all of these things when
Right.
people come in. So one of my first steps is to do usually I'll do an elimination diet while I'm waiting for the results of food sensitivity and microbiome testing to come back in those patients.
I see.
And yeah, so that's usually where I begin. And I have found that when you start to deal with the gut and not just say, okay, you're reacting to gluten or you're reacting to dairy, let's just stop those. You must do a gut repair protocol, right? Because if you just stop the foods and you don't do gut repair, in my experience, you're
Sure.
just going to get sensitive to the foods you are eating now, right?
Right. Which labs do you like to use the food sensitivity panels on and GI?
And there are a lot of good labs out there, but
Yeah.
I have to say this usually what I'll do, because I see a lot of Medicare patients, so I have to be
Mhm.
conscious of expense and price.
Sure.
I will start with Genova and do a Nutri-Eval, because the Nutri-Eval will give me at least a heavy metal screen. I'll understand the antioxidants, the vitamins, the minerals. I'll get some idea, is there some dysbiosis here, some yeast? I can glean a lot, lipid peroxides and so on. So it's for me, a screening test. It also helps to personalize the nutrients that someone needs, right? And I'll have that sitting right next to an endopat. So I'll know what's going on with endothelial function. And if I see the RHI is low, and the antioxidants are low, obviously those two are going to be complementary, and I know what I can do to help that person. I will also do a US biotech expanded food sensitivity test. If someone comes in and says to me, "Hey, I've been gluten-free and I'm having all these gut issues," I'll go to a Cyrex gluten cross-reactivity panel right there. I'll look at that. And so it's somewhat individualized and, somewhat driven by insurance, but I'm always trying to get the best testing that I can get.
Okay. So it sounds like, and tell me if I'm wrong, but just to try to share the key principles, when you're really focused on a Mediterranean diet, high in vegetables, low in saturated fat, low in junk food, trying to keep sugar levels down, keep antioxidant levels high, and then however that gets personalized, and then you're looking at the food sensitivity as another variable into how you personalize the diet, right?
Exactly. And of course, I'm trying to be conscious of the planet as well. I'm a firm believer that the more plant-based diet, the better it is for the planet.
Sure.
So I really believe if people are going to be using animal products, they should probably be a garnish as opposed to, a big steak sitting on a plate.
Yeah. And one of the things that's shocking a lot of us in the functional medicine community and just in the preventive medicine community these patients that have these phenomenal reactions and responses to carnivore diet, which kind of goes against everything we understand. And all of a sudden their inflammatory markers go down, their autoimmunity goes away, and like they're bloating and gut distension. I don't know what's happening. So what are your thoughts?
Yeah, I think all the inflammation is going away. I think a lot of that is being driven by when people, if like I'm thinking of one woman who walked in here, she was overweight, could barely walk. And I just put her on a full-on elimination diet, right? And I gave her animal products, and I took away her dairy, and I took away her gluten, and I so on. And she came back with a jump in her step. And I think what I'm doing in those situations is I'm really knocking down inflammation. I mean, it's going to be some people that will respond like that. And I think when you're dealing with autoimmunity, that's probably important, right? So it's not one size fits all, right?
Oh, I know, of course, but I just was wondering what you thought.
Yeah. And
so just calming down the inflammatory response and calming insulin down, is that?
Yeah, calming insulin down is key. I've been looking, although with COVID, I wonder what Doug Harrington would say about this. I usually look at the pulse score as well, because I'm looking at interleukin levels. And of course, everybody's looking at HSCRP and ADMA and so on. But following, when I do something, I don't just do it and let the patient go away, right? Any supplement I give, I'm either giving to replete a deficiency or I'm using it therapeutically. Any diet I give, again, I'm looking to replete deficiencies and use them therapeutically. I need to reassess and see where I'm at, whether it's the usually 3-month mark for nutrition to change. So you have to monitor what you're doing, and also how the patient is feeling, and be really calm. What's going on with the joint pain? What's going on with the skin rashes? What's going on with the brain fog? Right?
Yeah. So what do you think about vegan diets? And I know the literature is very conflicting all over the place with vegan diets. And what do you?
Yeah. So I think again, it's important to do it right. So I think it's important to make sure that you're getting your right legumes, your right beans, lots of vegetables. Frequently, I'll have my vegan patients make an additional green drink with protein in it. It's important to make sure you correct nutritional deficiencies, because I see some vegans with some mega nutritional deficiencies when I do NutriEval. So, again, it goes back to that. What actually are people eating, and what does it look like in their body? And I don't think there's any research out there that's really looking in the way that we're having this discussion, to be honest with you.
Of course. So what about diagnostic testing? So let's talk about an exam and then preventive. So obviously blood pressure is essential, right? And for you, when you look at blood pressure, or do you not think it's essential?
No, I do. I mean, in the office, you have to say, what can I do in the office, right?
So if you were to assess a patient and you're looking at the blood pressure as a variable factor, how do you like to confirm their blood pressure levels? Do you have them give you an average throughout the day? Do you do obviously do your office blood pressure? What are you doing for getting the most accurate blood pressure assessment?
If I can get the insurance to cover it, and I'm about to put in a bunch of them into my practice, I think if you can get a 24-hour blood pressure, that's ideal, right? Because we want to see what's happening with the blood pressure at night. Is it going down? Is it not going down? I think one reading in the office is probably not accurate to do anything. I get my patients to even buy cuffs and have them check an AM and PM blood pressure. I teach them how to do it. They have to sit with their feet flat on the floor, the arm at heart's length, heart level on the table. We have to make sure the cuff fits them properly. When they're on bare skin, they're not going through a big sweater. And if I can't get the 24-hour blood pressure cuff, I will have them monitor. In my office, I have a central aortic blood pressure machine so I can get not only a brachial, because what you'll find is as you move further away from the heart, blood pressure goes up. So the brachial blood pressure may be very different from the central aortic blood pressure, may be different by 10, 20 millimeters of mercury. I also encourage everyone to check both arms. When I train the fellows, I always remind them that the vascular exam is a bilateral exam. You want to listen to the carotids on both sides, check all the pulses on both sides of the body, check blood pressures on both sides of the body, do an ankle brachial index if you can. It's not very difficult. Get out the tape measure and do a waist circumference. People, BIAs we do in the office. So endopat we do in the office. So we really try to get an assessment of what's going on. And I also teach the fellows to look for other things, right? I mean, if somebody loses their lateral eyebrows, we're thinking of thyroid. If their conjunctivis pink, we're thinking of anemia. Xanthelasmas around the eyes in particular. I have a few patients, Burton's lines in the mouth. Look at the tongue. The tongue helps you a lot. If someone has a big tongue that's scalloped on the side, this person may have sleep apnea. They may just have too big of a tongue in their mouth, or as we say, too big a car in their garage, right? What does the uvula look like? What does the back of the tongue look like? Does it suggest that this person has food sensitivities, that something's going on in the intestine? What's going on with palpating the thyroid? Do you feel any masses and so on? So I think we have gotten away from physical exam.
Yeah.
General, and it's really sad to me.
Yeah.
That people, I have patients who say to me, doctors don't put stethoscopes on them, which I just find hard to believe. How do you pick up a carotid bruit? We're listening for femoral bruits. We're taking pulses straight down to dorsalis pedis and posterior tibial, taking socks off of people. You can even do an O2 sat on the toe, and and so on. So there's so much that you can do that I think we've forgotten about.
Yeah, I agree. We did a cardiovascular journal. We went over all that, except the advanced equipment testing. That's it's not accessible for the average clinician to have.
Accessible for everyone, and it's expensive. I mean, endopat is $25,000. Not realistic.
Right.
I do encourage people to get a BIA or some sort of body composition analysis if they can, because I think just relying on the BMI could be fraught with some errors, right?
And for those that have just, let's say, blood pressure cuff, the average clinician in practice, and they get an office reading, and then they decide, okay, this is okay. I do want to get a more accurate reading, and let's say they find a blood pressure cuff that fits them. They get an automated blood pressure cuff, and they start measuring the levels at home. Do you think just the morning and afternoon is good enough, or do you think how many times a day do you think they should do it? Do you average it together?
Yeah, I usually do morning and evening. I'd like to see what the AM blood pressure is on waking. I like to see the evening blood pressure. Usually most people can manage to do 2 a day. It's hard to ask people to do blood pressure. And what I find is when people start taking it and it's high, then they just keep taking it and it gets higher and higher because they get more and more anxious. And then I ultimately have to take the machine away from them. But if you do see those, morning high readings, if you see people that are waking up in the middle of the night, I just want to remind everyone that we do have an epidemic, if not a pandemic, of sleep apnea and sleep disordered breathing. And of course, it correlates with a lot of the obesity that we see out there, but it's not limited to obese people. And so to really do a good accurate sleep history is important. And very frequently when I do ASIs, so when I think of the functional testing that I do routinely in cardiology, I mean, I'm doing my food sensitivity in a 3-day microbiome test, and I'm looking at sleep apnea with technology by Vivos and by WatchPat. I'm looking for sleep disordered breathing. Especially people, if I do an ASI, an adrenal stress index, and I see high nighttime cortisol, I want to understand why that cortisol is high at night.
Sure.
What is going on? And frequently it's sleep apnea and it's missed.
That's a very good clinical pro. So high cortisol nighttime, rule out sleep apnea. That's
Think,
fantastic. Yeah.
think about that,
Yeah. That's very good.
you know.
So what do you find the people that have hypertension are the most impactful ways? Obviously, if they're overweight, they lose weight, that brings blood pressure down. But as far as, how much is meditation, yoga, stress reduction play a role? How much do nutraceuticals play a role? What are your favorite nutraceuticals, just specific to hypertension?
Right. So if we just stick with hypertension, first is getting a good food history. You'll be shocked at what people eat, as we all are. I do try to do a 1,500 milligram maximum sodium diet a day in my hypertensives to see if they respond. Some respond amazingly well. Oh my goodness, some will respond incredibly well. Some are less sensitive to salt. So if you want to say, what's your maximum salt a day? I'd say 2,000. I'm a little strict with salt. And dairy, by the way, is filled with salt, and people don't realize that. Of course, weight loss, right? For probably every pound of weight we lose, we can drop the blood pressure a millimeter or so of mercury. So getting one to their ideal body weight. Making sure if somebody comes in and they're on 3 blood pressure medications, think sleep apnea. Do not miss that, because that will drive cortisol. Cortisol will drive weight. It's all connected. So making sure we screen for apnea, because it is a cause of hypertension. And I always like to ask, what's driving the train? Like, what's going on in this person's life? For example, some people are so anxious and have so much emotional issues going on that's what's driving their blood pressure, right? Or some people are drinking too much caffeine and that's driving their blood pressure, especially if they don't metabolize it easily. So I think you have to, again, look at, I had a man come in here having, I think it was 10 Gatorade a day. And he was on 4 blood pressure medicines. And he thought Gatorade was good for him. And he had seen multiple physicians and no one did a nutrition history.
Yeah.
Like, what are you drinking? What are you eating? No one bothered to do that. So I think it starts there. And then if you want to go in the supplement world, you correct the nutrient deficiencies. There's at least one good study that shows correcting nutrient deficiencies improves blood pressure. You look at the stress. You'll get small reductions with meditation. They may not be huge reductions, but there's the TM study, 48% reduction in heart attack, stroke, and sudden death in people who do TM twice a day, black hypertensives. So that's powerful medicine. Again, looking at a full-on integrative approach. CoQ10 will lower blood pressure. Mortensen's study on CoQ10 for congestive heart failure, 300 milligrams a day, I thought was a good study. I use Rauwolfia, probably one of the few supplements that actually impacts blood pressure. I use magnesium. And again, everything I do, I'm monitoring impact. And so on. And lowering inflammation. A lot of people may not realize that CRP is not only a risk marker, it's a risk factor. It affects the angiotensin receptor. So higher levels of inflammation are going to raise blood pressure as well. So getting the inflammation down is key. And I always explain it to my patients. I say, you have a tree and the tree has some sick fruit. And in this case, it's hypertension. And yes, we may give, Bistolic because you tend to be anxious. And that's a good drug for people that are anxious with hypertension. Or we may give an ACE and an ARB because you're diabetic or you have a myopathy, cardiomyopathy, whatever drug you choose. But you should always go into the soil, right? And look at what's going on in someone's life. What's their macro and micronutrients? Are they sleeping more than 7 hours a night? Which, by the way, sleeping less than 7 hours a night is linked to hypertension, linked to cardiovascular disease, and so on. So are they sleeping? Are they exercising? Are they at their ideal body weight? How are they responding to stress and tension? So when I explain it to the patients this way, they really understand it, that no matter what their health challenge is, we can always go into the soil, which is all of our lifestyle medicine, that can impact their health. And of course, genetics play in, but I always use the genetics like the trunk of the tree, right? Your lifestyle interacts with your genetics to determine your ultimate health.
Well, as far as okay, what about when we get in now? If we get into like laboratory testing and just outside the functional or just in the conventional laboratory testing, things like particle size, oxidized LDL,
Yeah,
TMAO. What's a good panel for you to?
yeah. So the go-to and covered by insurance. So you want to know something about inflammation. So you at least want to know an HSCRP, which so you at least want to know that, and almost everybody can get that. You at least want to know what is your LDL particle number, right? How many LDL particles do you have? How many HDL particles do you have? What are your triglycerides, right? Because that's being driven by sugar and by carbs. What is going on with the thyroid? Because if somebody is hypothyroid, their cholesterol is going to be high, right? So you have to deal with the thyroid. You want to know at least a fasting insulin. At least I do. I want to know at least a fasting insulin. Of course, I want to know an A1C. So, these are some of the basic things. If I can get an ApoA, remember ApoA is the protein that surrounds HDL. We want that to be high. If I can get an ApoB, it's a marker for all the atherogenic particles, right? LDL, VLDL, IDL. So an ApoB is a good marker. And I think most insurance, just looking at insurance, would cover these tests without getting too esoteric, without talking about, ceramides and other more esoteric things. This is a good panel because if you see that high triglycerides, low HDL, like if you see triglycerides above 250, you can almost guarantee this person has small dense LDL. You're dealing with the atherogenic lipoprotein profile, almost always. If you see somebody with an LDL above 190, you're almost always dealing with familial hypercholesterolemia, right? So you can get a lot of basic information.
What about some of the markers that aren't really part of a routine insurance model, like oxidized LDL? Do you like that marker?
I do. I love it because it's telling me you don't want to have too many LDL particles, but you definitely don't want to have too many small dense LDL particles, and you don't want to have LDL that's damaged by inflammation, right? So that's telling us inflammation is at play, and that's obviously going to impact endothelial function and the laying down of plaque. So if you can get an oxidized LDL, I think that's terrific. And my targets, I think, are lower than most people's targets, and it might be because I'm a little jaded as a cardiologist. By the time I see people there, we just had a gentleman come in, 36-year-old, cardiac arrest, emergency bypass surgery, cholesterol, LDL 220, so we see people that are sort of an extremist a lot of times, secondary prevention. But, I say if you can get the ApoB to 60, if you can get the LDL to 60 and 70 to 70, these are in your secondary prevention. You can get your HDLP greater than 33, your LDL particle number somewhere in the 700 range, and HSCRP less than 1, I don't see these people progressing with vascular disease.
Right.
I don't see it.
What are you using as your baseline to monitor their vascular disease? Are you doing the coronary calcium score or using other types of specialized testing? What are you doing?
Yeah. So I want to know carotid IMT, very simple to get, and it's no radiation. Sometimes a picture's worth 1,000 words. We say for our people that you're sort of on the fence, should I how hard should I push? coronary calcium score, I still believe gives us a lot of information. Meta-analysis just came out that wasn't as pro coronary calcium score as I am, but I think it gives us a lot of information about laying down of plaque. And then, of course, endothelial function, if you can, with an endopat. You can even there's interesting research on ultrasound of the femoral artery, looking at plaque within the femoral vein plaque. You can look at the aorta for aortic plaque. When I see plaque anywhere, I treat it as secondary prevention. If there's calcium lining blood vessels, I go into a secondary prevention protocol. I don't wait. So easy thing, carotid IMT, coronary calcium, harder thing. Anyone who smokes should have an abdominal aortic echo to rule out aneurysm, and you'll see if there's plaque in the aorta. And of course, if you can get an endopat, it tells you something about endothelial function. And then you can go into your other testing, which is really based on exam and based on history and symptoms. So you can say somebody's hypertensive. You definitely want to look at an echo. You want to see the thickness of the left ventricle. You want to see if the left atrium is enlarged. You want to see how stiff the heart is. You're looking for diastolic dysfunction. This helps you because these are all reversible with treatment of the hypertension. And then if you...
Treatment of the hypertension, that's to go back to focus on hypertension.
Yeah, I'm just saying that when you think about your testing, why are you doing your testing, right? But what are you doing and why are you doing it? So there's testing for risk stratification, right? Like the carotid IMT, the coronary calcium score, looking at the abdominal aorta, doing your ankle brachial index, and so on. Those are your basic, to me, those are like basic screening tests.
Right. So what do you, with the coronary artery calcium score, as a cardiologist, what are you seeing? What are the most profound changes you've seen? I mean, if you keep the level if you keep the number the same and they're not progressing, would you consider that clinical success?
I do. I consider that clinical success because you have to remember the calcium is the tip of the iceberg.
Yeah.
And what's sitting under the calcium is all the soft plaque.
Right.
And that's really what we're reversing is the soft plaque. You don't necessarily see calcium disappearing. But everywhere you see calcium in the lining of a blood vessel, a plaque has ruptured, and then you get dystrophic calcification within the plaque. So, if you halt someone's coronary calcification, you're doing them a big service.
If you could only pick one coronary artery calcium score to monitor the patient blood pressure or a lipid marker, what would you pick?
Probably. I think blood pressure is critical, right? Yeah, you agree. Yeah, it's funny. We always say it's all important.
Yeah.
And it is, but
Right.
That's probably the one I'd go with.
Right. And, as a cardiologist, I mean, you're seeing patients at the extreme, like they're not coming straight to you. They're coming straight to you when they have an event or they have something serious happen or their physician identified they have severe heart disease. So you're kind of seeing patients that are really progressed, not so much as much prevention, right? You're not having an average guy coming off the street.
I have some of those, but usually they'll get here after something has happened or they had a coronary calcium score and some clinician said, oh, you have to be on a statin and I want some other approaches.
So if someone had, for example, a TIA or has angina or has some kind of vascular red flag that's coming up, that it's more serious, where does medication come in versus nutraceuticals? And, obviously if they're more progressed and you can't get the blood pressure down, it's a different story than trying to just play with a little bit of magnesium. But, where does that fit in? Because I think that's a really important call too for clinicians to know.
Yeah, and I think you have that discussion with the patients. Now, if I'm seeing somebody here who's overweight, inflamed, and has untreated sleep apnea, and I mean, this is my average patient, right, with metabolic abnormalities, I might say to them, look, we're going to start the whole lifestyle program. It's going to take a little bit of time to kick in. But at the same time, I may want to be treating your blood pressure because I want to protect you during this period of time. Or if I have a diabetic, I may believe that my ACE and my ARB are good to protect the kidney. So sometimes I will dive in with both nutraceuticals and medications, as well as lifestyle in those patients. I don't really, especially people who've had events, We presented this 36-year-old and someone said, well, let's give him red yeast rice. And I said, I think that's medical malpractice to give red yeast rice to somebody with a cholesterol of 405 who's had sudden cardiac death, right? That's not to say red yeast rice won't lower the LDL, but we need to be more aggressive while we're getting him embedded in a lifestyle change program.
And with those cases that are red flags and there isn't as much time and there's concern for another event, is blood pressure the most common blood pressure medication is the most common place you're going, or going after the lipids as well?
I go after both simultaneously. I don't make a distinction. Most of the inflammation I can get down with diet and lifestyle and repletion of nutrients. But if I'll give you a perfect example. I saw a gentleman with a lot of plaque in his carotids yesterday, plaque in his aorta, coronary calcium score still pending. It doesn't matter what it shows me at this point. Cholesterol was over 305 or so. And I put him on statin and Zadia, as well as a strict diet and weight loss program. And I'm going to see where we land. And as I said to him, look, we're going to monitor how we do. Repleted all his nutrients. He had lipid peroxidases that were high. His glutathione was low. We're making all of those corrections. I'm the first one to pull back drugs if you don't need them. I'm not afraid to escalate drugs, but right now we need to get these numbers under control.
Right. And with people that have really high cholesterol, like 300, when are you doing things like lipid electrophoresis, lipid phenotype test, looking for hypercholesterolemias? What factor is that in your workup?
Yeah, I really have only used electrophoresis in people that have had very high Lp(a) and vascular disease. And I haven't done it recently because the medications are so much better right now than they were years ago. And I'll refer people into research protocols like at UCSD, particularly for Lp(a). They're doing some novel research there. So most of my patients, I haven't had the need to do that. I can get them controlled with diet, lifestyle, medication, nutraceuticals. A lot of my tough patients are on triple therapy. They may be on a statin, they may be on Zadia, and they may be on niacin, right? I'm still a niacin fan. You can't take my niacin away from me.
Yeah, there's evidence for it. And do you have any issues with flushing, or what do you do with flushing? Do you use non-flushing niacin, or what do you do?
Yeah, no, the easy thing to do is start low and go slow, right? And there are some brands of niacin that cause less flushing than others. But if someone uses pure, niacin, nicotinic acid, you can buy a bottle about yay big for $13. That will light you up like a Christmas tree. So you have to, 250 milligrams with the largest meal for a week, then go to 500 milligrams, then 750, then 1,000. I usually check LFTs at 1,000 milligrams. Or you can use, sometimes I'll start with orthomolecular niacin, which my patients tolerate. And I will use 500 milligrams twice a day with food. And if they're taking an aspirin, take your aspirin before your niacin. So there are tricks for niacin. And of course, you don't give it to people with active gout. You don't give it to people with liver issues, peptic ulcer disease. But if you want to raise HDL, you want to lower triglycerides, you want to get rid of those small particles and get rid of LDLP, niacin could be your best friend.
Okay. So I just have two more questions for you really quickly. First question is, if you have a friend, loved one, a person that doesn't have cardiovascular disease, but they have a family history of it and all their markers are okay, and they go, listen, tell me the 5 best supplements and 5 best lifestyle, or, not the 5, but the best lifestyle and nutraceutical factors you would recommend if you were in my position.
So let's take a body, mind, spirit approach, body, mind, emotion, spirit approach, right? I would say everyone should learn to meditate and actually practice meditation or some form of stress transforming technique and go deep with that every day. Don't sweat the small stuff. Take a look at your personality. Are you someone who's angry, anxious? Where are you at emotionally? And we have to deal with that. I would encourage you every day to exercise. And as my patient, Deborah Zake, who just turned 100, a woman who brought the whole spa industry to the US, she said, tell everybody, walk double, eat half. And I think that's sage advice. Make sure your blood pressure is under control. Get off the sugar and simple carbs. Make sure you're sleeping, right? Because sleep is a key component of getting good restorative sleep to health. So I think all of these things are important. And of course, I think a plant-based diet is fundamentally important for health.
What about nutraceuticals? You think they're necessary?
Well, I call these foundational nutrients. So most of my patients are on vitamin D. Of course, I do omega checks, but most of my patients are on omega-3. I replete any nutrients that they need. If they don't need anything, they may be on a good multivitamin, like a phytomulti. And of course, it depends on what someone needs. And anti-inflammatories are important for me, but I think if you say, what would you give everybody? It'd probably be vitamin D, omega-3, which I tend to mix with NAC and curcumin. So I usually use a mixed brand of omega-3, and those are the key ones. An antioxidant, I think, is critically important. Vegetarians, of course, vegans, a good B complex. But I like to personalize it a little bit more. And maybe a probiotic like a Megaspora probiotic, a soil-based probiotic that adapts to what the gut needs.
Okay, that's fantastic. Okay, the last question. This is the question I would ask every single person after the last question of the interview. We have two different groups of people to make it binary in our group. We have those that are new to functional medicine and those that are really advanced and been doing this for a long time. What's your advice for the new people? What's your advice for the advanced people?
Well, for the people that have been doing this for a long time, please teach the new people. Please be a mentor and keep learning because I see there's a big discrepancy between, I have students in here every day in my practice, between people who've been doing this for a long time and people that are just coming up. To people that are just coming up in functional medicine, take it easy, go slow. Don't feel like you have to do everything at once. Learn a piece at a time. Don't be afraid to ask questions of your mentors, of the people that have been doing this longer. And don't feel like you have to know everything that your colleague who's been doing this for 20 years knows, right? Don't feel like you have to know what you know, Datis, right? You got to be gentle with yourself and learn as you go, because otherwise it could be like a drink from a water hose, fire hose. And you say, well, I just can't do this. It's too much.
Right. Yeah, that's perfect. That's great advice. Well, thank you so much for your time. That was really wonderful information. I really appreciate you. And thank you so much for everything you do.
Thank you. Keep up the great work. Thank you.